precision tree for non-traumatic shoulder pain. But I don't want you to follow this slavishly with your patients. What I want you to do is look at the tree, listen to the narration, and see if it makes sense. All right, if you can work your way through this and it's sensible, then you understand it. It's not there for you to follow each step in a sort of a slavish way. Just try to understand the tree. See if you agree with it. If you don't agree with it, say so, and write another one. I think ultimately this is the sort of thing that you need to aim for. If you can write something like this accurately and precisely, then you can be fairly sure you understand the subject. So this is obviously fairly complicated. I'm going to break it down into two smaller trees. One which will be full range of motion with point pain, or near full range of motion with point pain, and the other one will be limited range of motion with generalized shoulder pain. Okay, so onward. Let's look at the case of generalized shoulder pain, that is around the deltoid, front of the shoulder, top of the shoulder, just generally around the shoulder. Mostly aching, although it may be acute, more sharp pain on the movements, and significantly limited range of motion. First of all, when you look at the range of motion, if it's not exacerbating the pain, consider referral. Your first thought has to be cardiac, and then visceral, and then the neck. On the other hand, if the range of motion is producing the shoulder pain, then you know there is a problem in the shoulder. Whether or not there's another problem in the neck is a different issue, but you do know that the shoulder is the source of this pain, along with anything else. So let's look at what this can be. So coming down towards the right hand side there, towards osteoarthritis, arthritis. This is going to be a lot less acute than systemic arthritis is, and probably less acute than severe traumatic arthritis is. It will be mostly stiff and achy, but there will be more severe painful and range of motion. There may well have been a history of crepitus in this and previous histories of this coming on and going off. So this is basically an osteoarthrosis that you've managed to traumatize, this microtrauma, and made it inflamed. There's no systemic effects if it is osteoarthrosis to osteoarthritis. And it's going to be an older patient, obviously, or a younger patient with a history of fairly severe trauma to the shoulder that's degenerated early. As far as treatment is concerned here, we can come down into the same range of obviously capsulopathy. During the acute phase, you want to control pain. There's grade 1, grade 2 MOBs, electrotherapy, particularly muscle stim, which I prefer to TENS because you can't switch from TENS to muscle stim without the patient panicking. Analgesics and non-painful exercise, anything to reduce pain and move them on to the next stage. The other possibility here is it's a capsulopathy, and these can be very difficult to tell apart from each other, apart from the history. With a capsulopathy, there's not likely to be a history of crepitus nor previous episodes of this going on, although there may be a problem in the other shoulder. Not particularly common. This is the frozen shoulder adhesive capsulitis. It's less common than you might think. If you think back, how many of these have you seen? But this historically, from a subjective perspective, falls into 3 stages. One is, in the vernacular, is the freezing stage, and then the frozen stage, and then the thawing stage. But basically, you've got a stage there where the pain is increasing and increasing. Then it plateaus, doesn't get worse, but it doesn't get better. And then in the final stage, it will start getting better. The time for this can be, if it's left alone completely and nothing's done to shorten these stages, they tend to be equal periods. So it could be 3 months getting worse, 3 months leveling out, and then 3 months improving, or at 6, 6, and 6. But it's usually either a 9-month duration or a 18-month duration. There'll be no other joints or systems affected. but it may be associated with diabetes. The difference between this and a diabetic arthropathy, though, is that the capsule is the predominant thing involved here rather than the synovium. An infectious arthritis, they're unusual in the shoulder. These will get worse gradually and keep on getting worse. And if this is a severe infection, it will rapidly get worse, and the chances are you won't get to see it unless the patient's coming in off the street during the very early phases. So look for this to get a lot worse. If it's a very severe arthritis, you're almost certainly going to see an increase in fever. The patient's not going to feel worse. But with a chronic arthritis, that progression will be quite slow, and you may not see fever, or the patient may not feel particularly unwell. But it's a progression again. And the difference between this being an infection and a capsulopathy, which are both progressive in the early stages, is the age and gender. Now, generally speaking, with a capsulopathy, this is going to be middle-aged, mostly women, whereas an infection can occur at any point at all. If this is what you suspect, if it's a severe infection where the things get rapidly getting worse, it goes to the ER. If it's more chronic, you can fire it back to the physician, provided he's going to see them fairly quickly. And then you have a systemic arthropathy, so rheumatoid, diabetes, ankylosing spondylitis. The pain is generally more severe than osteoarthritis or capsulopathy, although capsulopathy can be really quite bad in the early stages. It's a rapid onset. It levels out fairly quickly. There's, if it's rheumatoid, there may be fever and general malaise, and there's an extended morning stiffness, more than 2 hours generally. The problem here is the difference between this and infectious arthritis. You shouldn't mess trying to figure out which one of the two it is. If this is the first episode they've had of this disease, then there may be no other joints involved or other systems involved, and if it's diabetes, there won't be. This either goes to the ER or an MD, much the same as the infectious problem did. So this is it basically. Most of your problems are going to fall into the first two, osteoarthrosis or capsulopathy, or if there's a traumatic origin, which none of these are, possibly a traumatic arthritis. The problem with traumatic arthritis is you have to differentiate that from a major ligament tear or a fracture. The next thing we'll look at is the pretty much near full range and point pain. So we have point shoulder pain and near full range of motion. The fact that the patient can move both arms up doesn't mean it's full range of motion. In order to really ascertain whether there's full range of motion at the glenohumeral joint, you have to stabilize the scapula and do it well, and then compare the two sides with the same stabilization. Otherwise, there's a lot of stuff that goes into the thoracic spine will extend and rotate on that side. The AC joint will accommodate some more range, and so will the SC joint. So in order to make sure this is full range of motion, you need to stabilize the scapula. Often there is some limitation there. So full range or near full range of motion, pain is usually anterosuperior on the shoulder, but it can be anywhere. So again, if the pain isn't exacerbated by the range of motion, even if there's full range of motion there, or limited range of motion, but you're not producing the pain the patient's complaining of, you have to consider other sources of referral from neck, heart, viscera, and so on. So if we follow on our way down, bursitis. This has to be an exclusionary diagnosis, unless you can see the swelling, which sometimes you can. But basically there's going to be tenderness over the bursa, but you're palpating through other stuff as well. So tenderness over the bursa can be tenderness of the stuff that's overlaying or underlaying the bursa, if you allow palpations a bit iffy. If the contractile test may be positive or negative, depending on the position you test it in and the force at which you test it. So if this is contractile tissue, a tendon bowstringing over the bursa, and you put the shoulder, say, into extension when it's bowstring over an anterior part of the bursa, then it will pull the tendon back onto the bursa, and that may be painful, whereas a maximal contraction in other positions may not be. Now that may still be a contractile problem. This is the problem. You have to get rid of the contractile tissues as a diagnosis before you hook on to bursa. As I said, if the bursa is visibly swollen, and then you have a bursitis, whether or not it's palpable. So if you've got painful swelling and it's down to the bursa, then the bursa is the source of the pain. You may be able to do this passively by compressing it. Painful arcs may be present, but again, you've got to exclude everything else before you make that diagnosis. If the bursa is infected, though, the onset is going to be gradual. It can be rapidly gradual, but it will come on progressively. And it can be very rapid progression, or it can be a slower progression depending on the acuteness of the infection. There may well be redness, there'll be severe tenderness, and it will be swollen, and you may see an increase in temperature and fever. If this is the case, it goes to the ER. If not, the bursa may be caused by systemic arthropathies or other systemic conditions, Reiter's gout and so on. So you need to check other joints, other parts of the system. Is there an enthesitis going on, multiple enthesitis, multiple arthritis, and so on. Have a word with the physician if you've got any doubt there at all. The other possibility of full range, near full range, is acromioclavicular arthropathy. Now, this is generally a sublux. It's a biomechanical dysfunction of the AC joint, and you have to test really now the glides of this to determine whether or not its motion is limited. Testing the shoulder girdle itself can be misleading. You can get more movement in the shoulder than you expect in the glenohumeral joint, and that will obviate any restriction in the AC joint. So you have to make sure of this by local inspection. So you palpate the joint line. This is your first thing. If the joint line isn't painful, it could still be the AC joint, but it could be the under surface, which you can't get to, but it's probably not. If palpation was negative, I would move on to the next option and palpate something else. But if it is tender, look at the joint lines, stress it. Cross-arm adduction will help do this. You can grind the joint, you can shear it, and finally you can glide it to see if there is limitation of movement there, or if it's unstable and hypermobile and painful. If you've decided on this being an AC joint problem, your treatment is going to be to manipulate it if it's jammed up. If it's inflamed, then your anti-inflammatory treatments deal with the pain and rehab, and then treat the etiology, which could be the thorax, could be the glenohumeral joint. Another cause of point pain is a labral tear. There's no specific tenderness, so we'll come back to this one because we can now palpate for tendinopathies, and we can either eliminate that or include it in, and then the elimination of tendinopathy takes you back to a labral tear. So let's move on a bit here. We'll look at tendinopathy. First of all, tendinitis. It's unlikely to be a tendinitis. If it is, you're looking for severe overuse. If not, if you're not seeing that, then think about medical conditions. But you're going to get exquisite tenderness on palpation. There's no digging around trying to find tender spots. This will be very, very on the surface. Your contractile test will be painfully weak, and stretching is likely to give you spasm when you do this. And the patient with a tendinitis is much more likely to have a generalized shoulder pain than a point pain here. So this will be a very unusual tendinitis for it to have point pain. So if you're finding this and you're seeing if there's systematic effects, then you send it back to the doctor. If there are no systematic effects, then you treat the pain, the inflammation, and so on. Ultrasound, treat the etiology, and so on, if you can do that. A tendinosis, the tenderness will be present, but you're going to have to look for it. One or both contractile tests will be positive, but not acutely positive, not severely positive. You're going to have maximal contractions and maximal stretchings to get a positive here. The treatment's similar though. High dose ultrasound now to deal with the degenerate area, frictions and so on. Now, if you find the tendons and the acromioclavicular joints are not tender, then you may have a labral tear. There's no specific tenderness here. There may or may not be clicking. There often is. There's often pain at night, not because it's ongoing, but because they turn over and catch it, or they lay on that side and they catch it. But it's a momentary pain that wakes you up. It's not a relentless ache that you'd associate with tumours or more systemic conditions. O'Brien's tear and or the load shift test will be positive. Now, if O'Brien's test is positive, then there's one or two possibilities. One is it's a transverse ligament tear. We're not going to do that. It's a bit rare and it takes a whole different presentation, but that's a possibility. But otherwise, O'Brien's test, if it's reproducing their point pain, this is going to be very indicative for this be a labral tear. If the load shift test is positive, but not painful, you may have a labral tear. There isn't the source of their symptoms if O'Brien's test is negative. So ideally, you want both of these tests to be positive. Let me repeat that. If O'Brien's test is positive and is producing their pain, then it's probably a labral tear. If O'Brien's test is positive and the labral test is positive, that's going to really confirm this being a labral tear. If O'Brien's test is positive, but the label, if O'Brien's test is negative, but the label test is positive, then they probably have a labral tear, but it's not necessarily the source of their pain. If this is due to trauma, there'll be an immediate onset, but a degenerative labral tear won't give you that sudden onset, nor will it necessarily require major activities to produce the pain. The activity in this case is a trigger. If this is limited movement, which it can, you can lose the last part of elevation and the posterior glide, then manipulate it. That should come back pretty quickly. It's still, you haven't got rid of the labral tear at all, of course, and you can wobble it to improve the muscular control rate, and that may give you a negative O'Brien's, but the labral tear is still present. So you need rehab and everything else that goes along with this. Okay, so this is now full range of motion or near full range of motion with point pain. And we're back. So as I say, look through this and then put it all together. And maybe do one for traumatic pain yourself and see how you do. This is really very instructive way of learning, and it helps cement and crystallize your thoughts on this. I do these things fairly frequently, and I've never done one the same way twice. There's always something that occurs to me while I'm doing it. It's a very useful method of learning.